Today I was asked to talk about PSMA PET for staging and for diagnosing prostate cancer. Before I come to that, I just want to briefly introduce our university hospital. The slogan of our university hospital basically says knowledge heals, which is a pun, maybe Wissenschaft heilen, which says like science also is important. And about the history, our university hospital is actually a pretty young university hospital. The hospital started in 1834 as a non-university hospital. It was founded in Munich. Other hospitals were there before, and was then changed to, the name was changed to the City of Munich Hospital, the Rechts, the Isar, and as was explained already, it just means on the right side of the river bank of the Isar River. In 1967 it became University Hospital. There are two universities in Munich. One is on the wrong side, on the left side of the Isar, one on the right one. Yeah. And then as I also talked briefly about PET MRI, which is really not a standard diagnostic tool and is also used in our institution mainly for experimental research. In 2010 we got the first PET MRI machine of the world. And when you talk about Munich, you also talk, of course, about FC Bayern München, which is our soccer club, and you all know that. And here is the Allianz Arena where they now are playing soccer. The main location is actually really in the city center. You see here, Klinikum Rechts the Isar, in direct proximity to the Hofbräuhaus, Munich, where you can have famous German beer. This is basically all the institutions that are connected to the university hospital. There are over 5,000 employees. I think I don't have to go through all these numbers. We have a lot of institutes and departments, and also interdisciplinary cancer centers and discussion rounds. And when you talk about urology, we are located here where there's the circle. And the chair of our department is Professor Trent. I think we have the size of our department is basically the same size here. Also, the urology department has. We talked to Arvis before. We have 4 operating rooms. We serve approximately 4,000 in-house patient cases a year. We have a comprehensive cancer center. We are also certified EBU training center, so there can also be, like Arvis was at our institution for 3 months doing endourology. So what is the focus of our department? Surgical oncology is really the mainstay of our hospital. We have around 300 radical prostatectomies per year, 100 radical cystectomies, 150 renal cell cancer cases, and we perform open laparoscopy or robotic surgery. Then another big thing is endourology and stone treatment. And we also do medical uro-oncology. That means we do have phase 1, 2, 3 trials with chemotherapy, with new substances, and we also, these are the main focus of our clinic. So, but now to PSMA PET. This is basically what I want to cover, and if I'm too fast, or if you have questions, don't hesitate, just ask right away. So I do also have slides in between summarizing what some of the previous said things, and what I want to briefly cover is targets and traces that have been used for PET imaging of prostate cancer. I will cover local detection within the prostate. Then I think this is a main focus, lymph node staging of high-risk prostate cancer, bone staging in prostate cancer. Also, this is a main indication for PSMA PET, then staging of recurrent prostate cancer. This is something that we are just looking now into. Can you also use PSMA PET for treatment response evaluation? And we don't have a lot of data on this, but this may also be in the future have some impact. And then I think, and this is also an important point, what are the pitfalls when you look at those pictures? Some seem very clear, and everybody can understand them just as when you look at them, and with other traces it's a lot more difficult sometimes to judge and to evaluate those pictures. But with PSMA PET, there are also some pitfalls that you need to recognize. Well, once again, back to Munich. This is Oktoberfest. Oktoberfest is very colorful. A lot of things are going on. It's very, nice for people to visit, and well, it's attractive. But imagine it in black and white. It's a lot less attractive. It's kind of boring. And this was actually us with prostate cancer imaging. We had CT, we had MRI, we had bone scan, all black and white, basically. And so we were very happy when the nuclear medicine physicians and radiopharmaceutical people start playing around with those targets. And this is a recent review, summarizing the current knowledge on the different targets. And I will briefly talk about the traces that have been used in the past for prostate cancer imaging, which is mainly choline-based tracers. There have been some experience with FDG. And then the other traces, basically like acetate or mentioned FACBC, they are not so much known about those traces. They are only small patient series, so I won't really cover these. Actually, ACBC was almost invented at the same time like the PSMA tracers, but it probably performs better than choline, but because PSMA was such a big hype about PSMA, basically there is not much done with it, with this tracer anymore. So there's some reviews and meta-analyses covering choline-based PET, and this is one from 2013, talking about choline PET CT in primary prostate cancer, more specifically for lymph node staging. And they summarized 10 studies, 440 patients, and found a sensitivity of roughly 50%, specificity of 95%. So really a low sensitivity for detection of lymph node metastases, but they report a high specificity. In that same issue, there's another analysis about mortality in primary and recurrent prostate cancer for detection using C11 choline or F18 fluorocholine. And when you look at here at the numbers, you do see sensitivity and specificity, which does not seem too bad, also for recurrent settings. But still, when you then look at their conclusions, they said not for primary prostate cancer, choline PET doesn't add much. For recurrent prostate cancer, there might be, so it's limited to the restaging settings they concluded. But this was 2013, so actually the main drawbacks that from choline or FDG is, FDG of course is based on glucose metabolism, and prostate cancer generally is more slowly growing, does not exhibit a lot of glucose metabolism. So they reason there might be in very advanced prostate cancer, fast dividing cells who need glucose. There might be some benefit, but for low differentiated, but for well differentiated, slowly growing prostate cancer, FDG PET might not be as useful. And for the choline PET traces, and choline basically looks at the cell membrane. So if a cell divides, it needs more cell membrane, and so choline is incorporated in this cell membrane of dividing cells. This might be of great potential, but for local tumor, it's not really reliable, and we looked at that in paper in 2011. For lymph node staging, also low sensitivity, and also in recurrent prostate cancer of limited value. So we were, again, very happy when the nuclear medicine physicians started playing with the PSMA as target. And one main difference between FDG, choline, and PSMA imaging is that PSMA is a protein which is located on the cell surface of most prostate cancer cells, and also so it shows an overexpression on most prostate cancer cells. So we're not looking at metabolism, we are looking directly on the molecular signature of prostate cancer cells. And this makes it then a promising target for imaging therapy, and a lot of different PSMA ligands have been developed in the past and also now. One of the first targets was the prostate imaging. I'm not sure, maybe some of you remember, that was 20 years ago. But the main thing was, it was a big antibody. It had to travel through the cell membrane to reach the target, had long turnover time, and it was not a PET imaging agent, it was SPECT imaging agent, so it was really not really feasible, and also the images were not as nice. And now with the development of antibodies, and especially small molecules targeting the outside active center of PSMA, these imaging have been really now become more and more in focus again. I won't show a lot of those molecular images because I'm a urologist, and what I can show you is first, they're different molecules, they are small, and they have one center which actively targets the same pocket, basically, so they have basically the same, they have the same target where they go to, and they are labeled then for PET imaging with positron emitters, like gallium-68. This is actually, this DKFZ 11, that means German Cancer Research Center. This tracer was developed there, and this is actually also the tracer that has been used worldwide now in most cases. So when somebody says gallium PSMA PET, mostly it's this tracer that is being used. There are other tracers, like this is another one which is then used, and I will show that in my second talk this afternoon about therapy. It's been used as therapeutic agent with another radionuclide couple. And then there are also now new tracers out which are labeled with fluor 18, which makes it probably even more easier to spread this technique. The images actually are the same, and if you have seen images with choline, you see a lot more background than here with the PSMA tracers, and you do see that they perform basically the same, and you do see, of course, also in patients a normal distribution of those PET tracers, and these are all so-called maximum intensity projections. That means you add all the, you have like a planar view of all the activity that you see. You see enrichment in the salivary glands. You see it's excreted, the tracer is excreted through the urine, so the kidneys light up, the bladder lights up, the spleen and the liver, and the small intestines also take up some of the tracers. But what is in this patient pathological are those metastatic lymph nodes. So to conclude this first part now about the targets and the tracers of PSMA PET, we have seen that there are multiple targets that have been identified and been used for PET imaging of prostate cancer. FDG and colon-based tracers show significant limitations, and that's why they are more and more abandoned, at least for prostate cancer imaging. And PSMA-targeted tracers are most promising. First, they don't rely on metabolism. They directly target the molecule, and this molecule is in most prostate cancer patients shows a significant overexpression. In the next few minutes, I want to talk about local detection. And we are in a very happy position that we have a PET MRI, but I can assure you, PET MRI is not something that you need. It's really more like a luxury diagnosis, but I still will focus or talk a little bit about it. I think for local detection, a multiparametric MRI examination is a very good examination. And I'll show you here a little cartoon. You see here you see here the prostates. These are T2 images. You see here the peripheral zone. You see something that is dark. But then with PSMA PET, when you have a PET MRI fusion image, you see a little, in more detail where prostate cancer is located. When you come back, this one you identify. In this case, it's really hard to see. In this anterior located prostate cancer, probably on biopsy, you don't go there. You go for the peripheral zone, you stick in your needle this way, but this you might miss. And again, this one is no cancer. Here is cancer present. So what you can add when you have a PET MRI, you have the multiparametric information from MRI, which is very good. Like here you have the T2 sequence. You see here the diffusion weighted imaging that shows you diffusion restriction in the cancer. You see here, and these are the contrast sequences, the first 60 seconds of the contrast material streaming in the cancer. And you see here the fusion images. So, and you have here also the molecular information that gives you the whole image, and so that you know, so that you know where to stick your needle in, basically. We also evaluated PET MRI and primary staging of high risk and intermediate risk prostate cancer patients that were scheduled for surgery. 53 patients, and were analyzed by PIRATES and a 5-point Likert score, and we did a patient and sextant analysis. And what we see here is when you look at the multiparametric MRI versus PET, and the score that is being given, that you have more patients, or this is the sextant analysis, where you don't really know, is the cancer present or no? So that means like a score of 3 in PET, in MRI, and this is less than with PET. You have either positive or negative, and when you add both informations, you're even better. And this is also the same not only for the sextant but also for the patient analysis. And what you can use this information for is basically for fusion biopsy. So when you do have, and you can also, of course, use just multiparametric MRI and do fusion ultrasound MRI fusion biopsy, and we can then translate those informations from the imaging to the biopsy room, and instead of having just a cognitive fusion biopsy, you can directly link those images. Of course, the disadvantage is special equipment necessary, expensive, and this shows a fusion biopsy system which was developed by our Department of Computer-Aided Medical Procedures, but there are other, of course, there are other fusion biopsy systems available on the market, but they're expensive. So they eventually will become cheaper. And this is just showing you in a small movie the linking between the PET MRI fusion image and the sonography image. So to conclude this part, which again, this is really luxury diagnostics and is more done in our hospital also for experimental research, but it combines the information, PET MRI combines the information obviously from multiparametric MRI and gallium PSMA PET, molecular information. enables visualization and localization of suspicious lesions and can be used then for biopsy targeting, or even if someone might consider targeted therapy or a radiation boost on a hotspot within the prostate. Well, now we move to a topic which I think is very important. Staging of high risk, primary staging of high risk disease. And here I have a case of a 69-year-old patient in really good medical condition. You see here the PSMA-PET positive prostate cancer, Gleason score 9 on biopsy, 42 PSA. Staging, CT or bone scan was negative. And you see here 2 CT scans. Obviously, if you want to go for surgery, this is a patient where you need to do an extensive lymph node dissection in our hospital. At least we perform those cases. And this is a node. Again, this is a very small node which is in the template field. So you would remove it without knowing that there's cancer. But on the other side, here we have a node behind the psoas muscle, which is really a very small 4 or 5 millimeter node that you won't take, that we won't take even if we do extensive lymph node dissection. So this patient was radical prostatectomy was performed. We found 3 lymph nodes that we lit up on PSMA PET imaging. 3 are positive, 39 removed, Gleason score 9, and without any other therapy, because we said, well, he had already lymph node metastasis. We first want to see how the PSA drop will be. He had a PSA of 0.2 without any adjuvant therapy. Then slowly rose to around 1. We did another PSMA PET at PSA of 1. Found a solitary bone metastasis in the symphysis or spubis, which was irradiated then, and he's now even more on follow-up. His PSA is not completely gone, but we believe that in this case we did the right decisions based on imaging. So we published a paper with 130 patients with intermediate and high-risk prostate cancer patients, consecutive patients. They all underwent preoperatively PSMA PET imaging with this tracer, like I showed you before. 95 of those patients had a PET MRI examination, 35 PET CT, but again, I'll show you in a minute the data. PET CT is, you don't need PET MRI. PET CT is really sufficient for this. And we performed in all those cases a radical prostatectomy and a pelvic lymph node dissection. Here are the fields that we removed during this surgeries. The nuclear medicine physicians and radiologists did a separate analysis for PSMA PET, for the morphological, and for the morphological imaging, that means CT or MRI. We evaluated the uptake of the tracer within the prostate, low versus faint and moderate to high, and the lymph node template fields were evaluated again on a Likert scale, which is shown here. So 1 definitely a metastasis, probably metastasis, we don't really know. No metastasis or definitely no metastasis. And then we again performed patient and a template field-based analysis. In 11 patients, 8.4%, we found no or only faint PSMA expression. Here's an example. Like here we have on MRI, we have the tumor, we see diffusion restriction, but this tumor has lost maybe PSMA expression, or the PSMA molecule has changed, is modified, so the tracer cannot bind to that pocket. But in most of those cases, we really see the cancer also taking up the tracer. In 36 of those 119 patients, we excluded from further analysis all those PSMA negative primary tumors. We found lymph node metastasis when we did the histological workup. meaning 108 of 678 dissected lymph node fields. And this is an example patient again. We see on the right side the tumor lighting really up in the fusion images. We see on MRI we have here on the other side a suspicious node, and here, yeah, we don't really know. But in PET, we see on both sides intensive tracer uptake, and this was a metastasis, and this is PSMA immunohistochemistry proving that there's prostate cancer. When we now look at the patient-based analysis and template-based analysis area under the curves, then we see that we do have a significantly, we perform better with PET versus morphological imaging. And when we look at the numbers, again, patient-based analysis or field-based analysis, and look at sensitivity and specificity, we see a 41 or 42%, 85% accuracy of 72% for CT or MRI. If you use PET, only PET, 75% sensitivity, 99% specificity on a patient-based analysis. When you go to the field-based analysis, sensitivity, of course, because you have a lot of fields which don't contain cancer, so it's normal that sensitivity drops, specificity rises, and again with PET, 76, 99%. So we have here an imaging tool for lymph nodes, which is more accurate than morphological imaging. So about those patients where we have false negative findings, in 11 patients, we could not detect the lymph node metastases. 2 patients had PSMA negative primary tumors. Of course, in a PSMA PET negative primary tumor, which is important information also when you do surgery, and then you have a PSA progressing PSA again, you don't need to bother doing PSMA PET because you know it's a PSMA PET negative tumor. And these, of course, you cannot also rely on the lymph node imaging. Then in 9 patients where we could not see the lymph node metastases, the mean size of the lymph nodes was pretty small, so range 1 to 5 millimeters, median or mean 3 millimeters. So PSMA PET does not detect every lymph node metastasis. Of course, it also has a spatial resolution which lies in a sub-centimeter range, probably less than 5 millimeter might be not picked up. 3 patients had only micrometastases, so really like 1 or 2 millimeters only. And in 6 patients was 1 template field, 3 patients with 2 template fields, which showed lymph node metastases. So other groups reporting their initial experience with PSMA PET. This was actually one publication in Urology where we were a little bit surprised because they found a very low sensitivity. And they included how many? 30 patients, so really a small patient number, smaller than our studies. And only 4 of those patients were identified. I think 12 had metastasis. But the thing was, in this study, they don't have PSMA PET on site. So they were just pooling patients from other institutions. And this was also then written in a reply from different institutions. They had probably different protocols, different traces, different activities, and they just relied on the written report. There was also no nuclear medicine physician in the author list, so this was a major point of criticism. And on the other hand, they performed PSMA PET immunohistochemistry in every patient, in every sample. So, of course, when you do PSMA PET immunohistochemistry, which is not standard routine workup of lymph nodes, you will detect more lymph node metastases than without this dedicated histological workup. And this again has to be set, of course, in correspondence to the other papers with choline where PSMA immunohistochemistry was not performed in most of those studies. Another paper, also in European urology, also in a mixed patient collective. I think there were like also 30 patients, 30, 40 patients. They basically found numbers similar to our experiences. But again, these are also early experiences. So to conclude this part for lymph node staging with PSMA PET, I think it's clearly shown also, even if it's retrospective series and retrospective evaluation, but it's clearly shown that it's superior to just morphological imaging. It adds information. PET-CT and PET-MRI perform equally, so there's not, for lymph nodes, there's really no superiority for PET-MRI. But then small size lymph nodes might still be missed, so a high-risk prostate cancer patient who has no lymph node metastases, if you go for radical prostatectomy, still needs a proper lymph node dissection, in our opinion. Okay, any questions up to here? You can really ask, just show your hands, no problem. Okay, whenever you feel you have something is unclear, I'm too fast or whatever, just tell me please. Bone staging. Bone staging is another important issue for prostate cancer patients, mainly done, of course, with bone scintigraphy. And as we started pretty early to omit bone scan, just to do PSMA PET imaging, and then we have information, lymph node, local bone. But, and this left us with, not a lot of patients we could compare. So when we did this analysis, we had 2,300 patients who underwent PSMA PET-CT. They were all PET-CT examinations. And we excluded all those patients who had no bone scan. And also we excluded patients where the time interval between both examinations was too long. So in this first analysis, we excluded patients if it was more than 90 days between the two examinations. Then if the therapy was changed in between those two examinations, if there were repeat examinations, we excluded that patient. So we had in the end 126 patients, some with initial diagnosis, 37 patients, recurrent prostate cancer in 49 patients, and advanced prostate cancer patients which already had castration-resistant disease. And we evaluated again on a per patient basis, but then also on a region-based analysis. So we have the skull, cervical spine, dorsal spine, lumbar spine. So we had like 9 different locations. And here's just an example. Of course, an example which is very placative. Here's the bone scan of the patient, here's the PSMA PET. Of course, you need to take out here the kidneys, the bladder, the salivary glands, then here also a lot of lymph node disease. You need to exclude that. But when you look at here, at the small lesions in the rib cage, you hardly can recognize them in the bone. On the other hand, you have here the metastasis. You clearly see it also here in the maximum intensity projection of PSMA PET. This is another example. This is a patient showing here a lesion, no lesion, unconventional imaging. Then the patient got treated. You still see here molecular activity, and you see now a calcification of this rib. That means it's like a treatment response. With ribs, and I'll get there at the end of my talk, you have to be careful because PSMA PET sometimes has a little flare in the ribs, so it's not so easy to evaluate the rib cage, but in this case we're pretty sure that this also represents a small prostate cancer lesion. The next slide is pretty busy, but I hope just to slowly go through it. So this is the patient-based analysis and here's the region-based analysis, comparing PET and bone scan. And these are, we just talk about all patients and not the 3 subgroups. We looked at the sensitivity and the specificity, and which is pretty high for both examinations. The specificity, sensitivity is better in PET than in bone scan. Area under the curve, you see the differences, and it was significant. So especially small lesions are more clearly seen on PSMA PET compared to bone scan. Region-based analysis, basically the same thing. So you see a significant difference saying that PSMA PET imaging is superior to bone scan. And this is then another analysis where we said, okay, maybe 90 days is a little bit too long of a time interval. We only take 30 days. So we had less patients, 29 primary, 27 with biochemical recurrent prostate cancer, 37 with castration-resistant disease, where we already knew he had metastases. And within 30 days, we compared the 2 examinations. And then, again, and I didn't tell you that, I mean, how do you know which bone lesion is a metastasis? You cannot biopsy a bone lesion or every bone lesion that you see in the patients. It's just ethical, not, you cannot do that. So you have, in all those papers, when you read them, you have a best valuable comparative. And what does this mean? That means you get all the clinical information, you get follow-up imaging, you take all this in consideration to then decide, is this a bone lesion or not, or like therapy response to a treatment to the bone, basically. And then when you look at the numbers again, sensitivity for patient-based, for bone scan, 89%, 98% for PSMA PET, sensitivity for region-based, again, PET performs better. And like I said before, especially small bone metastases will be detected earlier on PSMA PET imaging. So you basically, with one examination, you can have a whole status of the patient. Like in this case, you do see of bone scan, you see the bone metastasis also here lighting up. You see some other bone metastases that you don't see, technetium bone scan. But also, when you take the same patients, you have the CT, you don't see anything, and here you see your bone lesions, but you also have small lymph nodes that light up. Here also small lymph nodes that light up. Here the kidneys, of course these are not metastases, and also here the small bowel. Also this is physiological uptake of the tracer. So to conclude this part, for bone staging, it is superior to bone scintigraphy, increased sensitivity. This is the main thing. Especially small bone lesions are detected earlier, and it provides basically a one-stop shop staging for prostate, lymph nodes, and bone.
Sorry, how do you differentiate between physiological uptake and metastasis?
A very good question. I will. Some of these points will be answered like in the end when I talk about pitfalls of imaging, but. The thing is, within the prostate, you saw it, within the prostate you do have some background because normal prostate cells also have PSMA expression, but in most prostate cancer cells you have really like 100-fold increased expression of this protein. Lymph nodes should not light up. So when you have a lymph node that lights up, it is specific, it is a metastasis.
I'm talking about small intestines.
Small intestines. Small intestines, well, the thing is, small intestines, it's very seldom that prostate cancer metastasis to the intestines. This is one, then we see it in basically all the patients, and there is PSMA expression also in the neovasculature. So in vessels, blood vessels also. exhibits PSMA expression. That's why also in renal cell cancer, they also have PSMA expression. At least some of them. There are some reports on renal cell cancer also with PSMA PET imaging. And if you do, for example, primary prostate cancer patients and you do surgery and the PSA drops to 0, to non-detectable, then this is also proof that this cannot be metastasis. For once it would be a rare finding, but if you do have a focus in the intestines, which really takes up a lot of PSMA, you should be concerned maybe this is another tumor entity, which also has maybe in the blood vessels PSMA expression. Does this answer? Okay.
I have a question. I'm not asking at the moment for lymph nodes, but do I understand right that by magnetic resonance, which is now growing in sensitivity, like 3 Tesla magnetic resonance, diffusion magnetic resonance, that lymph nodes could be catched during prostatic cancer if they have become 1.5 centimeter big in diameter, when comparing to gallium PSMA, we could start from 5 millimeter. Yeah?
I mean, morphological imaging, CT or MRI, mainly depends or relies on size of the lymph nodes. Like I said, I mean, there have been also some work done with diffusion-weighted imaging. Also, I think you're also aware of the signaling and all those ferromagnetic imaging where you perform MRI, then inject those traces which go to the lymph nodes, and then do another MRI and compare and see if there's if the trace is not the magnetic particles are not taken up in the lymph nodes, saying that these are metastatic lymph nodes maybe. But the size is really also for MRI the main criteria. And we compared also most of the patients for the primary lymph node staging, we did it with a 3 Tesla multichromatic MRI. And MRI was, or on the other way, PSMA PET performed superior to MRI. And so I think, I'm almost there where MRI could be of value compared to PSMA PET. But for lymph nodes, I think PSMA PET will be better. And if you have one examination, PET-CT, PSMA PET-CT, covering everything that you need to know, I think also MRI won't be, there won't be so much space for MRI. Okay? Okay, now we're going to another topic which I think is probably, this is the main indication for PSMA PET at the moment. Most of the patients are examined at the recurrent stage of the disease. So you do have here on the upper slide, you have the CT only, patient who had been after radical prostatectomy. You see basically in CT you cannot really say anything about the local recurrence unless it's very big. PSMA PET, you clearly have a focus, you know, okay, you do have cancer here. Small lymph node. This is really a small lymph node. And it lights up. You also see here, PSMA PET is, of course, it is not so clear because of the imaging technique. It has a flare, so it looks bigger than it actually is. But this is just due to the PET examination technique itself. So for recurrent prostate cancer patients, we examined, and this was one of the earlier works, 474 patients with bicameral recurrent tumor. We excluded all the patients who had not undergone radical prostatectomy, whose PSA was below 0.2, because by definition they don't have prostate cancer recurrence, and although some urologists sent them for imaging. And we excluded also patients already in advanced stages who had already castration-resistant disease. And this left us with 332 patients. Most of them were examined by PSMA PET-CT, the 256, and some of PET-MRI. You see the machines that are used in our clinic, but I'm no physics expert. I think a PET-CT, it does not really make so much difference which company you use probably, but again, I'm just a neurologist saying that. So the PSA median was 1.7, so a pretty low PSA for most of the patients. And then we again compared, first we compared the performance of PET-CT versus PET-MRI. And we said in how many patients we see a positive finding and at different PSA cutoffs, 0.2, 0.5, 0.5 to 1 nanogram per mil, 1 to 2 nanogram per mil, and above 2 nanogram per mil. And then we found that basically, here the number of patients in each group and how many patients we detected. Excuse me something. Here you basically see the detection of positive findings is between PET-CT and PET-MRI is not significantly different. The nuclear medicine physician said, okay, sometimes the findings are just suspicious and sometimes they are highly suggestive of prostate cancer. And they said, maybe in this group, in this very low PSA group, they are a little bit more sure, a little bit more certain when they have PET-MRI, because they also have those functional sequences, diffusion-weighted imaging, contrast imaging, that might maybe give a higher diagnostic certainty. Maybe now look a little bit closer, there probably is no significant difference. So the main message is really PET-CT, PET-MRI for recurrent prostate cancer, not really significant difference. What is the difference is now again PET versus morphological imaging. And in 29% of patients, only PET showed positive lesions. Morphological imaging couldn't see anything. On the other hand, 3% only had positive findings on morphological imaging. Additional lesions, and this does not mean another lymph node nearby, but like a different organ system or lymph node pelvis, lymph node in the cervical area, 21% versus 6%. What are now those lesions that we see or detect more in PET? Mostly small lymph nodes. When you see here, these are all the lesions that are only detected in PET. Mostly small lymph nodes, followed by local recurrent tumor, and then there are combination mostly. And for morphological imaging, what are the? These were, I think, 9 patients. Mostly it was local recurrent tumor. And this now leads me to the next slide. For local recurrent tumor, because PSMA, the tracer, is also excreted in the urine, in the bladder, sometimes the local recurrent tumor cannot be evaluated that well. And here, MRI, multiparametric MRI, I think has a place. If you're really interested, if you don't see anything, that you might see something. Here you have a small nodule, no diffusion restriction, and positive on enhancing on contrast sequence of MRI. So this is a nodule highly suspicious for prostate cancer. This again is just tissue left behind. No diffusion restriction, no hypervascularity. So here MRI might lead you to the correct diagnosis. What is the influence on PSA velocity or doubling time detection rate? And here again, I have to say, because mainly it's the PSA value, the level of PSA, the velocity does not add so much, and also it's very hard to calculate at those very low PSA levels, because if you have a 0.2 to 0.5 in 6 months, and there could be also some measurements problems So at those very low PSA levels, those values cannot be calculated that well. You see a borderline significant correlation between detection rate and velocity. Between doubling time, we could not see in those patients any significant correlation. This is from the Heidelberg group, which they actually, I told you before, at the German Cancer Research Center in Heidelberg, they invented this special tracer, which is now mostly used worldwide. This is also patients with recurrent prostate cancer. They included 320 patients. Most patients had received radical prostatectomy before, but the thing is that 177 patients still had the prostate in. So you might have different thresholds here. But the detection rate, again, also showed a correlation to the level of PSA, also to if androgen deprivation therapy was used. So under hormone therapy, PSA of 0.5, you detect earlier or more cancer with PSMA PET imaging if the same patient has no ADT and has a PSA of 0.5. They could not see any correlation to Gleason score. We could see some correlation. So, and it is discussed that patients or prostate cancer patients with higher Gleason scores have also a higher PSMA expression, but to now we don't really know yet. And doubling time again, they also saw no correlation. Yes?
I have a question. During hormone therapy, you are saying the PSA could be lower?
Well,
at the same time, the target for PSMA, gallium PSMA, would be enough to catch the prostatic cancer.
Mm-hmm. The thing is, if you have the same level of PSA, you will detect more patients. But if you have a recurrent prostate cancer patient with PSA of 2 and said, oh, I want to do imaging, and you send him to imaging, but you said, well, I want to do something against this cancer and administer hormone therapy, what will happen? PSA will drop. You will not detect cancer. Because then when he comes to the examinations 4 weeks later, his PSA is 0.
Yeah.
On the other hand, if you have a patient under hormonal treatment, and when do you do those, when do you indicate these examinations? Of course, when the PSA is increasing. So if you have a PSA of 0.5 under ADT and he was for 0.3, so you do have a significant amount of tumor and you will detect it. There have been also discussions and there are animal experiments showing that when you do ADT, PSMA expression of the cancer cells increase. But it's not like when you first start with ADT, of course, it might be the case that on the cell PSMA expression increases, but most of the cells die because of the treatment, and then you will have less to detect. Well, we haven't said anything about the comparison to choline. I just said, well, it's not so good. Here are some images from a group, also again from the Heidelberg group. And here you see the choline, F18 fluid choline, methylcholine PET images. And here you see the, this is choline, this is PSMA. So you see here the liver takes up a lot of choline. You cannot see this small lesion. However, detection of liver metastasis by PSMA PET is still not so easy because the liver also takes up the PSMA tracer. Here again you see the kidneys lighting up, you see here also small intestines taking up. Here's bone, choline, PSMA. And here lymph nodes. Again, here with choline and here with PSMA, the same patient. And when you look at the maximum intensity protection, it's a little bit white here because of the contrast, but you see PSMA PET, it's very clean, and choline you do have a lot of background, and it's a lot harder to really evaluate those images. So they found in 37 patients, PSMA PET detected 78 versus 56 lesions, and 32 versus 26 patients. So in 6 patients, choline was uneventful, and only PSMA PET detected the cancer lesions. So they said it's significantly superior to choline-based PET. Another work from a group from Australia did the same thing basically in recurrent prostate cancer. PSA median 1.7, so a low PSA. Detection rate PSMA 34 of 38 patients versus 12 of 38 patients. Detected lesions again better. Tumor to background ratio. Also here you can see, I mean this is small lymph node, but also that this is another thing. Tumor to background ratio. We are talking now about the SUV values, the standard uptake values. This is something which is reported on PET examinations. So you do have background and you do have the lesion, and when you have the ratio is a lot different. It's a lot easier for you to detect those lesions. And here again you see local bone and lymph nodes. PSMA PET was superior in all of them. We actually did not do a lot of those comparisons, and this is when we started in 2012 with PSMA PET imaging. We did choline before. We published this other publication from our institution doing the same thing in recurrent prostate cancer. And actually when we did our publications, we basically stopped choline PET and just relied on normal imaging. And these were now 2 patients with choline PET CT scan, and within a few weeks later we did the new trace of the PSMA PET tracer. And here you see the lesions. This is the tumor to background ratio. It's a lot clearer. Sometimes, and this is wrong to think you don't need a medicine physician now to look at the pictures. I mean, here you, as urologist, you say, oh yeah, that's cancer, that's easy. You still need a nuclear medicine physician to evaluate those images, of course. But you see the detection, 1 to 2, from 43% to 92%. This is the group from Heidelberg again, 58%. But why is that? Because they included 1/3 of the patients still had the prostate present. So the PSA, of course, in those patients can be higher without having a recurrent tumor. So to conclude this, and I think this is really the mainstay today for PSMA PET imaging, to conclude this topic for recurrent prostate cancer staging, we see enhanced detection rates at low PSA values, below 1 even. It's more accurate than morphological imaging, more accurate than choline-based PET. And now, this is a little bit maybe the future. Treatment response evaluation. Here we have a 73-year-old male patient after a prostatectomy. This is score 9, PSA at 2 nanogram per ml. And here you see the CT slide. You don't see anything. With PSMA PET, you see, okay, here's a lesion. You still don't see anything. You treat this patient. You do radiation. There was a solitary lesion, so it's an individual treatment concept, of course. It's not in the guideline. But this was done in this patient. You treat this patient with radiation. Now you see the lesion. But is this cancer still present? You don't know. Another case. This is just somewhere in the bone. The metastasis is hidden. PSMA PET fusion imaging. Then you treat this patient. You see the lesion. You see no PSMA expression. And I don't know, is there a radiologist here present? Yes. No, okay. I have 2 cases here. Before, after, before, after. So just I mean, this is really, I mean, I don't want to put anybody on display, but this is just showing you how difficult it is with conventional imaging to decide which patient is profiting from a therapy and which patients are not. And of course, if you have clinical parameters, you always need to bring in the whole picture together. You have your PSA, you have the performance status of the patient. But here when you look at this picture and then this picture and this, it's really hard to say what patient is doing what. If you do have the PSMA PET imaging, you see this one probably is responding to therapy and this one is not. So this could maybe be the future for treatment response evaluation. Another case. This is a patient. He has been treated quite some medication. He had radical prostatectomy, cystoscopic prostate cancer again, radiated for local recurrence in 2003. ADT, had docetaxel, abiraterone, again docetaxel rechallenge, enzalutamide, and then started cabazitaxel in October 15. We knew by then he is castration resistant, of course, metastatic lymph node and liver metastasis. You see here the liver metastases. You see here the PSMA PET. Actually, and I think personally, I like this image better. So for liver, a good contrast CT or maybe MRI, or good contrast CT is probably better than PSMA PET. But again, here, small lymph node lighting up, and here, small lymph node also lighting up. Then he was treated and got a control scan. You see here nicely how the metastasis in the liver got smaller. As treatment response, you see also corresponding that the PSMA PET is also responding, but again, I think for liver evaluation, contrast enhanced CT is a wise decision. And then we look at the bone and the lymph nodes. The lymph nodes get smaller. I mean, it was small before, but it still takes up PSMA, and also this lymph node gets also smaller and also takes up still PSMA. So this is, of course, a patient who is responding to treatment, but he still has, of course, disease. So to conclude this part, treatment response evaluation, it might detect treatment responses earlier, especially for bone and lymph node metastasis useful, I think. Probably not as useful for liver metastasis or other metastasis. I haven't really covered lung, but also for lung it's basically not bad, and which leads me now actually to my last part here in this talk. For lung lesions, you need to be careful. Also, other entities might show some PSMA expression. So what are now pitfalls of PSMA PET imaging? PSMA negative tumor cancers, and these are less than 10% of primary prostate cancer, probably around 5 to 7% now, in our experience. In the recurrent prostate cancer setting, I think most of them are PSMA positive. And of course, if you have a negative tumor and you know it from the beginning, don't waste time doing PSMA PET imaging. It's not useful because you need to rely on morphologic imaging, like this one. Fusion imaging, negative big tumor. You see also here, diffusion-based imaging. I mean, this is a massive tumor that you cannot see. And another thing which is very important, PSA is not PSMA. The prostate-specific antigen that we measure in the bloodstream is not the membrane protein PSMA. They call almost the same, but they're two different proteins. So PSMA PET is especially useful in primary prostate cancer who don't have PSA expression. You cannot monitor them. If you have a PSA of 1 or 2 and he has a Gleason score 9 prostate cancer and lymph nodes, when you do the surgery, you can rely, of course, on morphological imaging, but if you know if this cancer is PSMA positive, you do have a nice examination for follow-up. So, especially in those PSA negative tumors. So I personally, when I do a surgery on a patient with a PSA negative high-risk prostate cancer, I say, okay, of course you need to measure your PSA, but half a year, 6 or 12 months later, I want this patient to get a PSMA PET. Because I want to also know by molecular imaging if this patient has responded or if there's still disease present, which I need to treat. What are other pitfalls? Benign lesions. And there are a lot of articles, and this is, I think I did this literature research in 6 months ago. There are more papers out now. Thyroid adenoma, Paget's disease, schwannoma, tuberculosis, adrenal adenoma, splenic sarcoidosis, ganglia. We did a lot of paper is not published yet about ganglia in the retroperitoneum. They also have faint PSMA uptake. Here you see a schwannoma. Here again the schwannoma, which is PSMA positive. Malignant lesions. Hepatocellular carcinoma, lung cancer, like in this case, that we saw, renal cancer, bladder cancer, also take up PSMA, or might take up. And now this is a difficult case again. This is a patient, 64 years old, with prostate cancer, newly diagnosed. The urologist sent him for PSMA PET imaging, and he got a bone scan, and you see here those lesions here, here, a lot of, and bone scan, a lot of lesions. In the PSMA PET, you see this lesion in the prostate, and now the urologist said, well, you have metastasized disease, we cannot cure you, so we give you hormones. Especially since the nuclear medicine from our department said, here you have some PSMA expression, here you have a small lymph node metastasis also present. And in the rib, you do have here another lesion, and you see the calcifications, so you have metastasized disease. Then I saw him in my outpatient clinic, and this patient, 64 years old, 3 of 8 course positive, Gleason score 6, PSA 12. This doesn't really sound like the disease he's having. He's an active sportsman, skiing, motor sports, diving, had multiple injuries. And I said, I think these are probably unspecific PSMA expression in the ribs. The others, they are so faint, I don't believe he has lymph node metastasis. And that fractures, or old fractures, take up activity in bone scan, it's also clear. So we performed, let's endly, and then I called the nuclear medicine department and said, well, how sure are you really? Are these, is this a metastatic disease? Because it doesn't really fit. And I said, well, not really so sure. And then we went and did a radical prostatectomy, and PSA 0, he's in follow-up doing fine. So to conclude, be aware of the physiological PSMA distribution. You need a nuclear medicine physician, of course, to really evaluate those images. Be cautious in the evaluation of PSMA negative tumors. Don't rely on PSMA PET in these patients. And consider differential diagnosis, benign and malignant lesions. So now for the end, what are now the main indications that we see for PSMA PET imaging in prostate cancer? And we try to do it like now in different categories. High category, high indication, primary staging of high-risk disease. And you can do PET-CT or PET-MRI. Biochemical recurrence with low PSA. If a patient presents with a PSA of 20, you probably don't need a PSMA PET or PSA of 50. You will see in conventional imaging also lesions. And on the other hand, don't perform imaging if it does not change your management. If you just do imaging to see the metastasis, this is no point. So do imaging if it would have impact on treatment. So at low PSA, biochemical recurrence, when you think maybe there's still room for local treatment, and PET-CT mostly is sufficient. Then, and this is luxury diagnosis, like I told you before, after several negative prostate biopsies, you can do multiparametric MRI, or, I mean, we do have a PET MRI, so we do PET MRI. And and I'll talk this in the afternoon. PSMA radioligand therapy, to monitor this kind of therapy, we also use PSMA PETCT. Intermediate indication, primary setting of intermediate risk disease, and it's more like the Gleason 7B, extensive disease. Gleason 7A in 3 or 4 cores, I would not go for PSMA PET imaging. And the guidelines also say you can do imaging, you don't need to do imaging. In high risk, you really need to do imaging. In treatment response evaluation, you can do PET-CT. Depends if you, and actually this is also like a, capacity is also a big issue. We do have a lot of prostate cancer patients. And if you do now all treatment response evaluation, we cannot handle them. I mean, there are too many examinations, and what no or low indication, suspicion of tumor without prior biopsy, I believe you still need to do a biopsy without doing MRI in everybody. Primary staging of low risk disease, you should not stage those patients because only very few will have metastasis. Active surveillance patients, we don't do it. So this is actually now the examinations that are performed in our clinic. And before we did choline, and then after the studies we just finished doing choline, and you see now we do in 3 months 400 examinations. So our nuclear medicine department, we are very happy with it, and we are also very happy with our radiopharmaceutical institute providing all these tracers. So we do really a lot of those examinations because we as urologists believe it changes management. And there are a lot of people helping, of course, and I don't want to go through all of them, but I work mostly with Matthias Isar. He is a attending physician at the nuclear medicine department in Munich, and there are also a lot of other people involved, and this is the whole thing is about interaction between the different disciplines. The nuclear medicine physicians need to talk to urologists, the urologists need to talk to them to understand each other more, and this is really the important thing. Okay, so this is the end of first half. Thank you.